Okay, it's being recorded.
أيوة كده
Okay.
تمام ظابط.
طيب طيب نبدأ بسم الله الرحمن الرحيم. Okay. Our webinar today is about contrast enhanced mammography and how it integrates morphologic and vascular breast imaging. Contrast enhanced mammography is an emerging technique, is being used now regularly in clinical practice, and breast imagers and breast clinicians alike need to familiarize themselves with this new technique. So my objective is to review the principles of the contrast enhanced mammography and review a quick review of morphologic and vascular components within the imaging modality to evaluate its diagnostic performance, its benefits and its limitations, and to discuss its clinical indications, how it's performed, and just go through very quick case examples. The digital mammography, the traditional mammography, provides anatomic assessment of the breast, as well as ultrasound, as well as tomosynthesis. All of these will provide anatomic assessment. Some cancers remain occult, non-visible on these modalities, especially in the dense breasts. Therefore, contrast enhanced mammogram emerged as a modality that will add functional or vascular information to the morphologic detail. It provides a more comprehensive review of the tumor, its size, its detectability, and its vascularity. The conventional morphologic breast imaging, which focuses on anatomical structures and visual appearance of the lesions, which includes the digital mammography, tomosynthesis, as mentioned, ultrasound, and non-contrast MRI. It evaluates abnormalities that include mass. When the digital mammography or conventional breast imaging detects a mass, it will assess its shape, its margin, the morphologic appearance of the lesion. It also can assess the density and presence or absence of asymmetric densities, assess presence of calcifications and architectural distortion. The morphologic imaging has got its limitations. The major limitation being the assessment of lesions or detection of lesions in dense breasts. Occult lesions can even present in very fatty breasts, but I think the main drive of vascular imaging would be in the dense breast. Overlapping tissues which can mask pathologies, and for this instance, assessment of tumor size might be problematic in morphologic imaging. And we all encountered that these lesions that are either we cannot measure them accurately in mammogram or ultrasound, or there is a size discrepancy between the two. It cannot, the morphologic image cannot characterize the tumor biology or angiogenesis. Tumor biology, what I mean by that is that, like in grade 3 tumors that we know, they grow very rapidly, they will become necrotic within the center, but you cannot see this on morphologic imaging. But on MRI, for example, you will see the central necrosis, which from imaging you can hint that this is probably an aggressive, rapidly growing tumor. It cannot assess the angiogenesis, and the specificity sometimes is an issue, and the rate of benign biopsies is more with pure morphologic imaging. So, what is vascular breast imaging? Used to be functional, used to be called functional breast imaging, but newly coming data is trying to move away from that term because on functional level, on molecular level, these imaging modalities do not really assess the function of these of the tumor cells, but rather assess the vascularity in the tumor cells. So basically, the whole idea behind the vascular imaging is it highlights the angiogenesis, the tumor angiogenesis, and this is the hallmark of cancer. So what happens basically in cancer? This is very brief, um, just explanation of what happens. Basically, the tumor starts small, and it gains its nutrients, its oxygen, its blood supply through diffusion. Then the tumor grows, and it becomes the diffusion it becomes insufficient to provide the enough nutrients, enough oxygen that the tumor needs to grow, and then necrosis happen as secondary to to insufficient nutrients. This will in turn stimulate vascular growth factors released by the tumor itself, and vascular growth factors will result in growth or formation of new vessels, which we call angiogenesis. The problem that is or actually not a problem, is beneficial for us in imaging, that these new vessels are actually abnormal, and they are not like normal vessels. They are very permeable, and they lead to leak of materials through their walls to the interstitium of the tumor. And this is what we use in vascular imaging, that when we give contrast, the contrast leaks through the abnormal tumor vessels and goes into interstitium of the tumor. And this what enhances what we see on imaging as enhancement. Um, Modalities that utilize vascular imaging or utilize this property in the tumor include the contrast enhanced mammography, MRI, of course, with gadolinium-based contrast, and there are two other modalities that are not routinely used, potentially might be used in the future, and that contrast enhanced ultrasound and molecular breast imaging, which is like part of nuclear medicine. But of course, in routine, conventional breast units, the last two modalities are not routinely used. The contrast enhanced mammography uses iodinated contrast that is similar to CT contrast, and dual energy acquisition. I will explain that in a minute. That capitalize on the inherent difference between the iodine and breast tissue in terms of attenuation. So the idea is normal breast tissue will not take iodine because the blood vessels are normal. The tumor tissue will take iodine because of the abnormal blood vessels. So what is generated? So is two images. It's a low energy image, which is similar to the standard mammogram, and the recombined image, which will highlight the areas of contrast uptake. Um, the benefits of contrast enhanced mammography, information is very similar to the to information provided by the MRI, without the need to all downsides of MRI, that is time, expenses, and claustrophobia and all of that. Um, so it emerged as a technique that is, approaches MRI in its sensitivity and specificity, and at the same time alleviates a lot of MRI disadvantages. It detects more cancers when compared to conventional digital mammography, when compared to tomosynthesis, and when compared to mammography plus ultrasound together. And probably you have heard about this PREG trial, the UK trial that was published in May, I think, where they compared all imaging modalities in the dense breast, and the results were very encouraging, that actually contrast enhanced mammogram and abbreviated MRI protocols both can detect many more cancers more than the other conventional modalities, even combined. Um, and the other advantage is that it can guide biopsies. And this is very important because for now, if we have a lesion that is visible, not visible on mammogram, and not visible on ultrasound, but only, for example, in the MRI, our only way of biopsying that lesion is to do MRI guided biopsy, and this is very difficult technique, not available even in the UK in very few centers. But contrast enhanced mammography provide us with another way to biopsy these lesions. So, because of these advantages and benefits of the modality and how easy it could be implemented within the routine daily work of breast unit, um, its use is increasing every day. There are so many vendors now offering mammography units with CSM capability. GE, Hologic, Siemens, I think, and Fuji. All of them they offer mammogram machines with CSM capability. Therefore, radiologists is most important than ever that radiologists and clinicians alike to familiarize themselves with the technique. The other thing is the price, the availability, the accessibility of contrast enhanced mammograph is predicted to be much more, it's predicted to be much more available than the MRI. So in countries like Sudan, for example, it's much easier to provide access to contrast enhanced mammograms than to provide access to MRI. So it is predicted in the future that it will be the choice for lower income countries or countries with limited access to MRI. Uh, just very few words about the physics. I won't go any deep because I don't know. But just to understand how it is being done, how the technique works. So this graph here is shows the attenuation values against the energy, the kVb of the X-ray beam. So these two lines here, the green line is the fat and the orange line is the glandular tissue. And you can see that with increase, the attenuation of the fat and the glandular tissue is highest when the kVb is low, and it drops when the kVb values has increased. The typical mammogram, I think it's between 25 and 26, 27 kVb. This is what we see normally in mammograms. This is the iodine. The iodine in these values in 20 is the kH of iodine is higher than that, it's at 33 kVb. So in these values that we normally take the mammogram at, the iodine is virtually not seen. But when we take a high energy image, typically between 44 and 49 kVb, then that exceeds the kH of iodine, and this is where iodine is of high density on the images we see. So in the low density, low energy image, we can see the glandular tissue, the fat, is very similar and not at all inferior to conventional mammogram. And at high energy images, we can see only the iodine basically. So the high energy image cannot be perceived by the human eye, and I will show you an example. Then comes the imaging processing, which will do a process of recombination and subtraction at the same time. That's why we don't call it subtracted images. We call it recombined images, and will show us the enhancing lesions. So this is the process basically. So this is the low energy image, which is similar, as I said, not inferior at all in details provided to a conventional mammogram. And this is the high energy image, which, as you can see, we cannot see anything in it by the normal human eye. And this is the recombined image, which will eventually show us the areas that enhances. This process is all automatic. done by the machine. Uh, all what we do is after we inject the contrast, we just position the lady for normal mammogram. We position CC view, MLO view, and the machine will do the rest. So it's a bit of workflow for the CSM. It's a bit of work there, but it's much easier, much shorter than an MRI. First thing, we have to screen patients for contrast allergies and do basic renal function. If all okay, then the lady will come on the day. Um, will have a cannula inserted. Then she will have a contrast media injection, normally about 100 mils of contrast. And we normally use an automatic injector. Manual injection is not recommended for contrast enhanced mammogram because we need a rapid injection of 2 to 3 mils per second. Imaging will begin 2 minutes post injection. So there is a timer on the machine. When you after you inject contrast and you flush with saline. Sorry. And after you inject contrast and you flush with saline, you will start your timer. And the 2 minutes you will use them to position the lady on the machine. So then we position for standard CCs and MLO views, as I said, and then the machine will generate the low energy and recombined images for you. We normally keep the vascular access, we keep the cannula for 15 minutes after setup, just to make sure that the lady doesn't develop an allergic reaction or anything. So similar process of what's done on the CT scan. Some units even because of the because we don't still do that much of that many number of contrast enhanced mammograms. They incorporated their mammography, their contrast enhanced mammography machine close to CT, so they can just use the same injector. But most units, of course, they have like their own injector. So this is the process of imaging, basically. We basically so this is the so which side we image first depends on local protocols, but most units they image the normal breast first, because normally you have an idea which abnormal breast is. So they start with the normal breast to maximize the contrast, to allow time to maximize contrast concentration within the side of interest. So we do a CC view of the non-index breast, then a CC of the index breast, then MLO of the index breast, because we want to do the same side, and then lastly the MLO of the non-index breast, and these are the recombined images that are generated. We come to the clinical indications. So many clinical indications. Most of the clinical indications are, or all of the clinical indications actually are those of the MRI. And that's why there are so many enthusiasts of contrast enhanced mammogram, as I said, because it spares the ladies the MRI. It makes everything within our control in breast units, and our ladies within the area with the familiar people that they have already known, with the familiar mammogram machine. So that's why the clinical indications are similar to MRI. We use it in the symptomatic clinics. If there is lady over 35 years of age and suspicious clinically, ideally now they don't go for a conventional mammogram, but for a contrast enhanced mammogram. Sorry, just give me a second. سوري يا جماعة معلش بس باب البيت كان بدق هنفتح من شنو. Um, so, so if there is a symptomatic lady who's 35 years old or 65 years of age or older and suspicious clinically, ideally she should have a contrast enhanced mammogram to facilitate detection of lesions in her expectedly dense breast. Um, Also, if we have a lady that's younger than 35 years of age, who normally go for ultrasound first, but ultrasound is suspicious, we preferably send them for contrast enhanced mammogram rather than a conventional mammogram. Um, Suspicious findings on digital mammography, we use them on screening of high-risk patients. As I said, there's a big trial which was published this year, and before that, many other trials that um, uh, uh, suggest additional imaging for screening high-risk ladies. And now contrast enhanced mammogram will probably be incorporated in screening high-risk ladies. Screening recall assessment. Um, uh, when we recall a patient from screening, we ideally would want to do everything uh, to minimize patient anxiety, to be able to give a diagnosis from on one setting and so on. And contrast enhanced mammogram will be very beneficial. Staging of non-cancers, as sometimes the size of the tumor, especially in the dense breast, and you will see examples of that, is difficult. And we used to send these ladies for MRI for staging, a local staging of the cancer, but now we can do that with contrast enhanced mammogram. Also, one of the other uses is when we have a lady with axillary node positive for metastatic breast carcinoma, which is not visible on conventional imaging. Also, these patients used to go for an MRI, but now we usually do contrast enhanced mammogram. Response to neoadjuvant chemotherapy is not still an approved indication, especially in the UK, but probably it will be in the near future. There is no enough evidence for now, but probably it will be in the near future. Surveillance of breast cancer patients, after breast cancer diagnosis and treatment, these ladies usually go for surveillance, mammograms for 5 years post diagnosis, and in the dense breast, normally these cases will be discussed on the MDT if whether we need to do surveillance with MRI, but now contrast enhanced mammogram will probably also be used for that. Contraindications are mainly the contraindications to contrast, if there is contrast allergy or if there is a risk of contrast-induced nephropathy. The other contraindication is the significant immobility, because you need to mobilize the patient quickly between the contrast injection and the positioning for mammography. You have 2 minutes to do that. So if you have a lady with poor mobility, this probably won't be suitable. And MRI won't be suitable as well. So. Okay, so contrast enhanced mammogram is a type of vascular imaging, but at the same time, as I said, the low energy images are similar or equivalent to standard mammogram. So they provide the same morphologic information that the mammogram will provide. That's why we will not be losing any information by doing the contrast enhanced mammogram. So it will provide us with all the descriptors that we need, if there is a mass, the shape, margins, if there are calcifications, distortion, or density patterns in the breast. And it is essential that to assess to look at the low energy images first when assessing a contrast enhanced mammogram. The recombined images, of course, will highlight the regions of contrast uptake, which is representing neoangiogenesis and increased perfusion through those areas. So it will enable us to detect otherwise occult lesions, assess the lesion activity, and differentiate benign versus malignant enhancement patterns. Um, as I mentioned, there are advantages of contrast enhanced mammogram over MRI. It's faster, it takes around 10 minutes, the whole procedure, versus up to an hour for the MRI. It's less expensive, it's more accessible, it's more tolerated by patients. We did a survey in our unit, and on the ladies who have done, because when we started to do contrast enhanced mammogram, we were doing both because of the the staff is not used to it. We are radiologists. We didn't used to report it. So when we started, we were doing both contrast enhanced mammogram and MRI for the ladies, and then we did the research or survey. We surveyed these ladies, and I think 100% of them, they said they prefer to do contrast enhanced mammogram over an MRI. Shorter learning curve, when you are, or you already read mammograms, you have already done 50% of the job of learning, how to report contrast enhanced mammograms. And if you used to report MRIs, again, you probably know 90% of the work. So it's much easier for trainees and radiologists to learn interpreting and reading contrast enhanced mammograms compared to reading MRI, for example. Um, the MRI still holds the advantage that it doesn't utilize ionizing radiation, and this is an issue with the screening, especially high-risk screening. So if we are proposing contrast enhanced mammogram to be a screening modality for high-risk ladies, are we going to subject these ladies to higher radiation doses every year? Especially these are young ladies, maybe some of them start at 25. So this is an issue for contrast enhanced mammogram, especially the radiation dose is higher than the conventional mammogram. MRI is still superior for evaluating the extent of the disease, but in clinical practice, I find that the surgeons, they want to know um, if this if this tumor if this breast is conservable or not. So sometimes it doesn't matter really the exact size of the tumor. Um, Other things that MRI is still superior is implants. Breast implants, imaging of breast cancer, with breast implants present in the mammograms, we know that the breast implants are very difficult to image, and sometimes it will block basically or obscure lesions. So still MRI is superior in imaging implants, and MRI is still superior in imaging lesions that are close to the chest wall, especially in the inner breast, and which will be away from the field of the mammogram. The sensitivity and specificity. The MRI is marginally, with a negligible values, more sensitive than the contrast enhanced mammogram, but the trade-off is the specificity. It was found that the contrast enhanced mammogram is actually more specific. So on our daily clinical practice, if something enhances on contrast enhanced mammogram, we are more suspicious, we are more concerned, because MRI, everything enhances. So MRI specificity is an issue. The rate of positive biopsies, benign biopsies with MRI is much higher than contrast enhanced mammogram. And we found that also within the period of time that we were doing both contrast enhanced mammogram and MRI for our patients, we saw that things that were detected by the MRI and not by contrast enhanced mammogram, all of them were benign. For reporting, for interpretation, still the LCR did not provide an independent PIRAX lexicon at the moment, but it did recommend that to use the MRI lexicon. So for the low energy images, we use the mammography descriptors because, as I said, it is comparable to the conventional mammogram. And for the recombined images, we use the MRI descriptors. Okay. So our report should start always by the breast density, um, uh, and the sorry, by the background enhancement. This is where I'm talking now about recombined images. So the report should start by describing the background parenchymal enhancement because the background parenchymal enhancement, it has the ability to obscure lesions if it is high, as in this last image. So it might be minimal, moderate, or significant, and that should be mentioned in the report to denote, the sensitivity of the test that we are describing. Um, so in the interpretation, we describe the enhancement as um, mass or non-mass enhancement. Um, The mass enhancement, then we describe the shape, the margins, the internal enhancement, whether it's homogeneous, heterogeneous, or rim enhancement. As I said, same descriptors of the MRI. And non-mass enhancement, we describe its distribution, whether it's focal, linear, segmental, diffuse, and how the internal enhancement looks like. And then there is the focus of enhancement, and the focus is very, very small focus of enhancement that is less than 5 millimeter, which might not represent a 3D lesion. Okay, coming to quick examples. These are images, all of these images are from open access images over the internet. I just wanted to put examples of all the indications of the contrast enhanced mammogram. In this example, you can see this is very, very dense spread. This is a conventional mammogram. You can't really see a definite lesion there, and you can pass it as normal if you are on a screening setting. This is the tomo. And you can see in the tomo, you can see the speculations, the architectural distortion, because the tomo is good in showing the architectural distortion. But on the contrast enhanced mammogram, you can see clearly an enhancing mat there with small satellite nodules around it, and this is a malignant mass. So compared to the mammogram, the conventional mammogram, you can see the difference is huge in detecting that cancer. Another example of detection, very, very dense breast, as you can see, and there is abnormality on the ultrasound, which was also non-specific, but when they did the contrast enhanced mammogram, you can see a large area of non-mass enhancement, which is also seen on the MRI, on the MIP here as an area of non-mass enhancement, and this was a lobular cancer. As I said, the other thing is the characterization, the specificity of the lesions. So, this is a lady, high risk lady. She underwent a screening. On her right side, there was like a well-defined mass. On the left side, there's just linear area of asymmetric density. When they did the contrast enhanced mammogram, there was like very beautifully outlined benign mass on the right side. There was also some septation or some area of low density present within the mass itself, and this is reported as probably benign. And this was an area of non-mass enhancement on the left breast. Biopsy revealed that this is a fibroadenoma, and this was invasive ductal carcinoma. For staging, sometimes we see the lesion, we see the mass clearly on the mammogram, but if we want to accurately measure that mass, it's very difficult. So in contrast, enhanced mammogram here in this example, you can see there is a mass, and in addition, there are satellite nodules around the mass, enhancing nodules around the mass, denoting that this is a multifocal disease. So the area of the disease is much larger than is seen on conventional mammogram. Another example of multifocal disease, multicentric actually, detected only on contrast enhanced mammogram. You can see multiple areas of enhancement, which denotes multicentric disease, and this breast is not conservable. So it upgrades the surgery in matter of 10 minutes for this modality. Another example of how the staging can be performed by contrast enhanced mammogram. So this is a very dense breast. The lesion in contrast enhanced mammogram is very big, and also it's a multicentric disease. And this cannot be measured accurately in this mammogram. I don't know if you can see this, but this is calcification detected by mammogram. And when they did the contrast enhanced mammogram, there is a large area of non-mass enhancement. And as you know, calcification is one of the areas that difficult to manage in breast imaging. So we see calcification. We do ultrasound. Normally, we don't see anything on ultrasound. Most of the time, we don't see anything on ultrasound. And then we rely on stereotactic biopsy to biopsy the calcification. But here it's obvious that there is a mass behind it that makes it upgrade instantly to a BI-RAS 5. Monitoring of neoadjuvant chemotherapy, as I said, is still an area of debate, still an area of research. But as you can see here in this example, in this baseline contrast enhanced mammogram, you can see the mass clearly, and this is post-treatment, and you can see that the mass has disappeared, which is consistent with full response or complete radiological response. Here on the MRI, you can see that there was enhancement. She has got a lot of background parenchyma enhancement, but the area of the tumor was enhancing in the baseline MRI, and now it's completely black as necrotic or fibrosed, maybe on the post-treatment MRI, which is consistent with the contrast enhanced mammogram. Here, another example of complete imaging response, no enhancement whatsoever on the post-treatment mammogram. And this is an example of a partial response where the tumor has shrunk, but it did not completely disappear. Another example of partial response through the treatment course. So this is the baseline. This is the mid-cycle mammogram, and this is the post-treatment mammogram. You can still see some enhancement there, and this is the appearance on the MIP MRI. Biopsy, contrast enhanced mammogram can facilitate biopsying lesions that were previously only accessible by MRI guided biopsy. So the procedure is very similar to its combination of contrast enhanced mammogram and stereotactic biopsy. Basically, we inject the lady, we position her. You have to do contrast enhanced mammogram first before you bring her for contrast enhanced mammogram biopsy. So you know where the lesion is. So you bring the lady, you inject the contrast, you position her in the best position you think for the accessing the lesion, and then you will target this with your stereo biopsy. You can see all of that. Of course, the contrast will not stay throughout the procedure, but you've already determined your target, so you don't need the contrast to stay. Actually, once you determine your target, the lady is compressed. She cannot. She will not move, and the target probably will not move. So you know that you have biopsied the target. As I said, the limitations is still the availability because you need to update your mammogram unit if you need to incorporate contrast enhanced mammogram. There is a need of vascular access, and this is a problem in breast units because normally nurses are not there, so the radiographers need to take training and obtain certificates and so on. So it might obstruct the workflow that you don't have somebody to cannulate in the unit, simple as that. Contrast reactions, as I said, is still a problem. Radiation, it's higher dose than the conventional mammogram. As there is still inconclusive evidence for its use in staging or in neoadjuvant chemotherapy monitoring, but in real terms, actually, in practice, we still use the contrast enhanced mammogram for these purposes. For staging, we use it because we want to biopsy and determine extent by biopsy. So if we do contrast enhanced mammogram and I biopsy an area 5 centimeters from the original tumor, that's a multicentric disease and end of story. So we do use it regardless. For neoadjuvant chemotherapy monitoring, we still use it. It's not the gold standard. It's still the MRI is the gold standard, but some ladies cannot go and undergo MRI. Those with pacemakers, those who are claustrophobic, we still use the contrast enhanced mammogram, but this still needs to be an NDT decision because it's still not licensed or not recognized for this use. Breast implants, still MRI. We do not prefer to do contrast enhanced mammography. And lesions are close to the chest wall or at the extreme inner breast. They are not included in the mammography field, as you can see here, and they are better seen with MRI. What else? Future will carry a lot, I'm sure, for contrast enhanced mammograph. There are so many enthusiasts around the world for the technology. Artificial intelligence is coming. The use of screening is used in screening in high-risk population and use of screening in dense breast. These are also areas that are being discussed and researched heavily. And even incorporation within the tomosynthesis-based contrast imaging, which is even a step higher than the contrast enhanced mammogram itself. So it is combination of tomosynthesis and contrast enhanced. Thank you very much.
Thank you very much, Dr. Rabab. That was incredible.
Thank you very much, Rabab. Fantastic presentation.
Thank you.
Clear contents, strong structures, and focus in our needs. I was about to ask you about one point regarding the limitation, and you have mentioned it at the end. But let me ask you in a different way. Regarding the posterior breast and close part to the chest wall, we know that this is one of the major limitations regarding mammography in general, and definitely it will affect the mammographic contrast studies. How do these limitations affect your practice in staging breast cancers?
Well, as I said, for these lesions, we prefer to do an MRI still.
But you don't know during daily practice, you don't know if there are lesions in the posterior breast, unless there are continuation or the extent of the lesion and you could not see it. Sometimes there are skipped lesions at the back of the breast. So how we can manage such cases, and we don't know about it.
Yeah, these cases, unfortunately, they present symptomatically. They present in one of two ways: either symptomatically, and then when we do the ultrasound and we do the mammogram, they are out of the field of the mammogram. We do the ultrasound anyway for every symptomatic lady. Then we find the lesion that is in the inner posterior breast, and then if we will immediately recommend an MRI for her.
Sorry, before go to the second point regarding ultrasound. So you are doing the whole breast screening ultrasound for the staging?
No, no. If the lady presents symptomatically with a lump, she will have a mammogram and ultrasound anyway. So if the mammogram misses the lesion, it's outside of the field of the mammogram, and then we find it in the on ultrasound. Then we don't have a mammogram for this lesion. We direct her towards an MRI. Especially in the posterior lesions, we need also to assess if there is a pectoral muscle or stressful invasion. So anyway, she will do an MRI. The other ways that they present to us when they are detected incidentally on CT scan or PET scan done for another reason, for example.
My point here, if you have a lesion يعني outside the field of view on mammography, okay, maybe your index lesions in the middle or the anterior breast, doing ultrasound searching, you are going to do only targeted ultrasound for that lesion, or you will scan the whole breast?
Normally,
if you will not scan the whole breast, you might still miss the posterior lesion as in for the staging. This is my point.
Yeah. So as I said, it depends on the practice. But in the UK, if the lesion is visible on mammogram and on ultrasound, and there is concordance between the two, we don't normally do any further staging. But if the lesion, for example, is visible on ultrasound and very obscured on mammogram in a very dense breast, for example, we do either contrast enhanced mammogram or MRI. Or if the size of the lesion is different, there is discrepancy in size between the ultrasound and the mammogram, we still do a third modality for staging. So we don't do, if we have a very fatty breast and the lesion is very visible on the mammogram, we can size it and it's concordant with ultrasound size, we don't do any further staging really.
So still there is chance to miss posterior lesion breast on staging?
Yes.
Yeah.
There is a chance. In Saudi Arabia here, they do whole breast ultrasound. I can see. And yeah, you can really find other lesions. But the thing is, in the UK, if there is cancer, we did mammogram, targeted ultrasound, they did breast conserving surgery, they did just a wide local excision. They do radiotherapy post-surgery, which is the main target for radiotherapy is to kill the other little lesions around the breast. And the other thing, they do surveillance for 5 years post-treatment. So this patient is not
because my practice, it was on Saudi Arabia. I used to do the whole breast for staging, whole breast ultrasound. And
it depends on the practice.
We do found some other lesions. Some other lesions in the posterior breast outside the field of view on mammography. Before, I did not practice yet. I did not practice yet the contrast enhanced mammography. But we do we used to do ultrasound screening the whole for staging, ultrasound breast for staging the whole bilateral whole breast.
In the UK, you have 15 minutes per patient, so you cannot afford to do a whole breast ultrasound at all. It's not. So and the overall what they argue is their practice is evidence based, and their overall cancer detection rate and mortality rate is comparable. So they don't see the need why you should do whole breast ultrasound at all.
Different practice, yeah. So in your practice, you have a high percentage of missing posterior cancer breast on contrast enhanced mammography?
As I said, we cannot know what we have missed, yeah. But we did.
You didn't notice some cases, يعني, or
no, as I said, the thing is, the current indications of contrast enhanced mammography is not screening yet. It is not incorporated in screening yet. The high risk screening is still done with MRI.
yeah.
So what we do contrast enhanced mammography mostly for symptomatic breast. And for symptomatic breast, we actually we already have an idea where the cancer is. So for staging, still we didn't see any patient we have missed a lesion in.
You have mentioned you have mentioned at the beginning in your department when you start to do contrast mammography.
Yeah.
You did
We know.
both MRI and contrast mammography. Regarding this study,
we
what
didn't.
did you find?
No, there were no missed lesions. There were no missed lesions. But as I said, the thing is, the indication itself was not detection. The indication was either staging, either.
Yeah.
We didn't find any lesions that we didn't see any lesion on MRI that we did not see on contrast enhanced mammography. If that's the question.
Good.
There were no more lesions detected on
MRI as
MRI
compared with contrast enhanced mammography. So
the MRI detected few other things, which, as I said, turned out benign. Anything that the MRI that detected.
This is a comparability regarding the higher sensitivity of MRI versus mammography and more specificity of contrast mammography over the MRI. This is going with that, with the literature result.
Yes.
Okay, nice. Any of the attendees who want to share us his experience in such contrast enhanced mammography or comparability with MRI?
So in Rabab, in our department, we are using contrast enhanced mammography in the two-way clinic for every case who is P4, 5, which is suspicious for the surgeon. Yeah. And now we are introducing P3, which is sometimes nothing, just nodularity or benign findings, it's for audit P3 lesions. But P4, 5, this is the practice since 2021. And I have done audit for all contrast enhanced mammography cases done from 2021 till 2024. I can share you this audit later within next year program. But not much to say after Dr. Rabab presentation, which is most likely what I found in the audit is comparability to MRI. So most of the cases we didn't need to do MRI after contrast enhanced mammography, either it is solitary lesion or we can see anything like local staging, no need for MRI, especially in dense breast and HER2 positive patients. So that was very helpful. 68 of the 100 cases didn't do MRI already. And from those who did MRI, 80% of over 80%, 80 something, were comparable to MRI. The non-comparability of the cases were mostly associated with DCIS, early stages lesions, DCIS mostly, which is seen as non-mass enhancement on MRI or linear enhancement or ductal lesion without calcifications. Other non-comparable,
sorry, Wala, this point, but not seen as ground glass enhancement on contrast enhanced mammography?
Nothing.
Not enhanced at all.
No enhancement at all. which is I think only 2 or 1 of the cases. No enhancement at all.
Low grade DCIS.
Low grade DCIS, yes.
Yeah, low grade, yeah.
So what else? I didn't one of the cases, no enhancement on MRI, no enhancement on CAM.
Low grade.
That was low grade lobular. Yeah.
Low grade.
Low grade lobular. So other cases like sometimes the fair like focus of enhancement satellite, which is associated with extensive disease. We could see that on MRI, we couldn't see in contrast enhanced mammography. So they did biopsy that because they can see it on TOMO, and they find it B2, which is benign. And that was more toward contrast enhanced mammography, that it is specific.
Yes, yeah. Going with the
specificity.
Higher sensitivity of MRI, but low specificity.
Yes. So it was very useful because then
literature.
It changed our practice now. So every dense case now is for contrast enhanced mammography, no need for MRI, because usually in the MDT, when it is subtle on CA, on normal mammography, as Dr. Rabab Alhassan said, when it is very dense breast and subtle on mammography and seen on ultrasound, they usually ask for MRI. But when we present this audit, now they are asking for CAM because it is easy. It is easy and feasible and no need for waiting list.
So it changes the practice very, very rapidly.
Yes.
And as enthusiasts are, I'm one of them. The enthusiasts are so many. That's why I think we will see advances very, very rapidly in the future. And as I said, إنه مثلا في بلد زي السودان مثلا, I think it's much easier to provide a contrast enhanced MRI, mammogram than to provide an MRI.
Yes.
Yeah, you are right. You are right. But first to have mammography machines.
We are hopeful. We are very hopeful.
But you are right. Definitely, you are right. It's much easier. Yeah.
And the other thing
and cost effective, even cost effective.
The patient compliance itself. يعني احنا قلت لك عملنا سيرفي 100% من البيشنتس هو اللي هم عملوا الكونتراست انهانس ماموجرام والام ار اي هم they said they prefer to do contrast enhanced mammogram.
Yeah. Right.
So compliance, يعني البوزيشننج بتاع الام ار اي بريس is terrible. ف
yes.
بكل
and long time more than 45 minutes.
أي prolonged التايم بتاع الستدي is long time الام ار اي not like ال contrast mammography. لكن برضو الكompression يعني they try to avoid the compression. لحد هسه برضو نحن are trying to convince ladies to do a mammography itself.
But when they have cancer, Dr. Rabab, they will do anything because
exactly.
now it is life or death.
Yes. بعد كده الدلع بيجيب.
ايوه.
عشان كده انا بحب to explain to the patients يعني البيشنتس بيجوا خصوصا في منطقتنا يعني in the Middle
They
East.
tolerate it very well, more than
when
even
we explain to them
MRI.
that we are worried about this I might be malignant, ما بيقولوا اي حاجه ثانيه, they do everything you want. لكن يعني the ideal, as they say, the ideal imaging modality for the breast is yet to be discovered.
Yeah,
you are
it
right.
depends from case to case, from one scenario to other. It depends on a lot of things.
You see, that is why every time I put the 3 circles, interdigitating circles in my lectures, saying that it is complementary. The modalities of the breast are complementary. Always are complementary. يعني مرات نلقى one modality to give informations يعني انت ما متوقع على other modality متوقع منها تديك information ما تديك الالتراساوند دي مرات تطلع اشياء انت ذاتك لما تحتار يعني تديك information much detailed information انت متوقعها to see it in the mammography but no you will see it in ultrasound and the vice versa.
دي واحدة من الأسباب اللي خلت الكونتراست انهانس ماموجرام نفسه popular, إنه أنت ممكن تعمليه in your setting, in your unit. where you have the ultrasound machine, you have your mammogram machine, everything is within one place وديديكيتد للبريست ايميجينج. فالكومبارابيلتي دي والكورليشن دي هو خلى الكونتراست ماموجرام مور بوبيولار لانه
popular.
يس يعني مش
مع
ترسل
انه recent
study
مع انه recent لكنه
يعني
ايوه.
احنا لما تجيكي بيشنت في فاست تراك كلينيك وتمشي للكلينيكال وتكون suspicious وتكون انت عايزه answer for this patient right now much easier انك تعمل لها contrast enhanced mammogram، تلقي الليجن، تعمل البايوبسي، end of story.
Yes.
من انه تعمل
من تعمل لها booking for MRI.
exactly.
You're right.
Thank you very much يا جماعة for listening، وإن شاء الله نتلاقى قريب.
Thank you very much, Dr. Rabab.
شكرا كتر خيرك
See you in our next webinars inshallah. Presenter and attendee.
إن شاء الله فرصة سعيدة، ولا ما أعتقد تلاقينا فيرتشوالي قبل كده.
أيوة صح، فرصة سعيدة. أنا يعني مالك نهائي، أنا جيت أنت مشيتي.
وين جيت أنت؟ في تشيستر؟
لا أنا في ستوك أون ترنت.
قريبة.
أي لقيت حسن حسين
كاشف.
أيوة. سبحان الله، بس جيت كده عرفت إنك مشيتي السعودية.
بالتوفيق إن شاء الله.
نتقابل على خير إن شاء الله.
رباب أنا أرسلت لك مسج.
أوكي. تمام.
أوقف الريكوردين؟
أيوة خلاص.
شكرا جزيلا يا جماعة. شكرا.
الله يسلمك، تسلمي. Just a minute.